Hello, class. Welcome to Flourish Nursing Academy. This is Tutor Godwin. We'll be discussing ulcerative colitis. Ulcerative colitis is a recurrent ulcerative and inflammatory disease of the mucosal and submucosal layers of the colon and rectum. The peak incidence is between 30 and 50 years of age. 10% to 15% of the patients develop carcinoma of the colon. Etiology 1. Genetic predisposition. 2. Environmental factors may trigger disease, viral or bacterial pathogens, dietary. 3. Immunologic imbalance or disturbances. 4. Defect in the intestinal barrier causing hypersensitive mucosa and increased permeability. 5. Defect in repair of mucosal injury, which may develop into a chronic condition. Pathophysiology. Etiological factors cause the superficial mucosa of the colon to undergo diffuse inflammation or shedding of the colonic epithelium. Bleeding occurs, leading to ulcerations. The mucosa becomes edematous and inflamed. The disease process usually begins in the rectum and spreads proximally to involve the entire colon. Clinical manifestations: diarrhea, painful straining, increased bowel sounds. There often is weight loss, fever, dehydration, hypokalemia, anorexia, nausea and vomiting, and iron deficiency anemia. Crampy abdominal pain. Diagnostic evaluation. Diagnosis is based on a combination of laboratory, radiologic, endoscopic, and histologic findings. Laboratory tests. Complete blood count. Hemoglobin and hematocrit may be low due to bleeding. White blood count may be increased. Decreased serum levels of potassium, magnesium, and albumin. Other diagnostic tests. Barium enema assesses the extent of disease and detects pseudopolyps, carcinoma, and strictures. Flexible proctosigmoidoscopy or colonoscopy findings reveal mucosal erythema and edema, ulcers, and inflammation that begins distally in the rectum and spreads proximally for variable distances. A CT scan can identify complications such as toxic megacolon. Rectal biopsy differentiates from other inflammatory diseases or cancer. Management. General measures. 1. Bed rest, IV fluids, replacement, clear liquid diet. 2. For patients with severe dehydration and excessive diarrhea, fluid may be recommended to rest the intestinal tract and restore nitrogen balance. 3. Drug therapy. Sulfasalazine, azulfidine. Mainstay drug for acute and maintenance therapy, given orally and is systemically absorbed. Oral salicylates, such as mesalamine pentasa, olsalazine, dipentum. Mesalamine enema available for protosigmoiditis, suppository for proctitis. Corticosteroids, treated with 5-aminosalicylic acid preparations to benefit from their potential steroid-sparing effects. Immunosuppressive drugs purine. Analogues 6-mercaptopurine and azathioprine may be indicated when the patient is refractory or dependent on corticosteroids. Antidiarrheal medications may be prescribed to control diarrhea and abdominal pain. Surgical measures I. Non-curative approaches. Possible curative reconstructive procedure at a later date. A. Temporary loop colostomy for decompression if toxic megacolon is present without perforation. B. Subtotal colectomy, ileostomy, and Hartmann's pouch. C. Colectomy with ileorectal anastomosis. Reconstructive procedures. Curative. A. Total proctocolectomy with permanent end ileostomy. B. Total proctocolectomy with continent ileostomy. C. Total colectomy with ileal reservoir. Anal or ileal reservoir, distal rectal. Anastomosis. Procedure of choice. Multiple reservoir shapes can be surgically created. However, the J-shaped pouch reservoir is the easiest to construct. D. The ultimate surgical goal is to remove the entire colon and rectum to cure the patient of the disease. Complications: perforation, hemorrhage, toxic megacolon, fever, tachycardia, abdominal distension, peritonitis, leukocytosis, dilated colon. On abdominal, life-threatening. Skin lesions, erythema nodosum, pyoderma, arthritis, ankylosing spondylitis. Colon malignancy, liver disease, sclerosing. Nursing management. Assessment. 1. Review nursing history for patterns of fatigue and overwork, tension, and family problems that may exacerbate symptoms. 2. Assess food habits and use of any dietary or herbal supplements used as alternative therapies that may have a bearing on triggering symptoms. Milk intake may be a problem. Many patients use vitamins, herbs, and homeopathic remedies without realizing the effect on bowel function. 3. Determine the number and consistency of bowel movements and any rectal bleeding present. 4. Listen for hyperactive bowel sounds. Assess weight. Nursing diagnoses. 1. Chronic pain related to the disease process. 2. Imbalanced nutrition less than the body's requirement related to diarrhea, nausea, and vomiting. 3. Deficient fluid volume related to diarrhea and loss of fluid and electrolytes. 4. Risk for infection related to the disease process, surgical procedures. 5. Ineffective coping related to fatigue, feelings of helplessness, and lack of a support system. Nursing intervention. 1. Promoting comfort. Follow prescribed treatment of reducing or eliminating food and fluid, and instituting parenteral feeding or a low-residue diet to provide general rest, but also to slow peristalsis. 2. Be aware of skin breakdown around the anus. 3. Cleanse the skin gently after each bowel movement. 4. Apply a protective emollient, such as petroleum jelly, etc. 5. Achieving nutritional requirements. Maintain an acutely ill patient on parenteral replacement of vitamins, fluids, and electrolytes. 6. Provide a well-balanced, low-residue, high-protein diet to correct malnutrition. 7. Determine which foods the patient can tolerate and modify the diet plan accordingly. 8. Administer prescribed medications for symptomatic relief of diarrhea. 9. Maintain fluid balance. Maintain accurate intake and output records. Check weight daily. Monitor serum electrolytes and report abnormalities. Observer for decreased skin turgor, dry skin, oliguria, decreased temperature, weakness, increased hemoglobin, hematocrit, BUN, and specific gravity, all are signs of fluid loss leading to dehydration. 10. Minimizing infection and complications. Give antibacterial drugs as prescribed. Administer corticosteroids as prescribed. Provide conscientious skin care after severe diarrhea. Administer prescribed therapy to correct existing anemia. Observe for signs of colonic perforation and hemorrhage, abdominal rigidity, distension, hypotension, and tachycardia. 11. Providing supportive care. Recognize the psychological needs of the patient. Fear, anxiety, and discouragement. Hypersensitivity may be evident. Answer questions about the permanent or temporary ostomy, if appropriate. Initiate patient education about living with chronic disease. 12. Home care considerations. Pouchitis. Patient undergoing one of the continent restorative procedures, cock, or ileal reservoir, and anal anastomosis, must be alert for a common late postoperative complication called pouchitis. The symptoms include increased stool output, cramping, MPS, and malaise. It is thought to be related to stasis within the pouch or reservoir and usually responds to metronidazole. Assess for these symptoms and notify health care. Food blockage. Patient with a temporary or permanent ileostomy must be alert for signs and symptoms of a food blockage. This is a mechanical blockage of undigested foodstuffs at the level of the fascia. It is most likely to occur in the first 6 weeks, postoperatively when the bowel is edematous. Symptoms may include spurty, watery stool with strong odor, decreased or no stool output, abdominal discomfort, cramping or bloating, and stomal swelling. Nausea and vomiting are late symptoms and require immediate attention. Treatment includes avoiding solid foods and drinking clear liquids when symptoms occur. Patients with ileostomies must never take laxatives. Applying a pouching system with a larger opening to gently massage the abdomen around the stoma, and pulling the knees to the chest and rocking the body back and forth. A warm shower or bath may help with relaxation. If the blockage lasts for more than 2 to 3 hours, or if nausea or vomiting occurs, seek medical attention immediately. It is best to instruct the patient on how to prevent a food blockage by limiting certain foods. The first few months after surgery, Chinese vegetables. Reintroduce problem foods slowly into the diet. Patient education and health maintenance. Teach each patient about the chronic aspect of ulcerative colitis and each component of care prescribed. Encourage self-care in monitoring symptoms, seeking annual checkups, and maintaining health. Alert patient to possible postoperative problems with skin care, aesthetic difficulties, and surgical revisions. Encourage the patient to share experiences with others undergoing similar procedures. Bed rest, IV fluid replacement, clear liquid diet. For patients with severe dehydration and excessive diarrhea.